And so the World Health Organization classification of soft tissue tumors are lipid type tumors, fibroblastic, fibrohistiocytic, smooth muscle, parasitic, skeletal muscle, vascular, chondroosseous, uncertain etiology, and then there's some non-classified tumors that we'll talk about as well. When you try to characterize masses with MR, it's relatively straightforward. You've all been doing this for years. On T1 weighting, if it's hyperintense, you're really looking at lipid-containing tumors or blood. You can get methemoglobin. And then you can also, if you have ganglions or abscesses, you're going to get highly proteinaceous fluid, which can also be bright on T1. Excuse me. And then melanin can be bright with melanomas. For T2 hypointense, we're really looking at more fibrous tissue, calcium or hemosiderin. And then T2 hyperintense, we're talking about things that have a lot of increased free water within them, like cysts or myxoid lesions, which have a lot of intracellular water within them. So you can go through kind of a differential based on hyperintense signal on T1 weighted image, whether or not there's fat. And then I can look at that. And here's just another classification system based upon T1 weighting. You have hypointense on T2, no, with a bunch of basically everything, yes, and then you're really talking about fibrous lesions or calcific lesions. And then hyperintense on T2, as you really might expect. So, and then if it appears cystic, you see whether it's homogeneous or not, and then you're dealing about typical cyst, heterogeneous, or if it's an atypical location, then the contrast can be helpful to see whether it's solid or cystic, whether it's vascularized or not. And then there are a lot of different lesions that can look cystic, including some of the malignant lesions that we'll talk about as we go forward, especially the myxomas can look very cystic. And here's some other lesions that can be malignant, that can look almost like cysts if you're not careful. And we'll see some of these. This talk will just go over kind of an overview of soft tissue masses, and then if we have time later, we'll look in a little bit more detail. So what do you look at on an MRI to try to determine whether the lesion is malignant or not? Well, size, if it's greater than 5 centimeters, it's more likely to be malignant than benign. But then again, you still have to look at the characteristics. You can have popliteal cysts, which are over 5 centimeters, which are clearly going to be looking benign. So, but if it's a large lesion, especially if it's not cystic, then you have to be very concerned. If you have surrounding edema, you have to be primarily concerned about inflammation, but some malignant lesions can also have edema around them on the fluid-sensitive images. If it's heterogeneous on T2 signal, then it's more likely to be malignant. If you have a rapid rate of enhancement, and then if you have destruction of the tissues around it. So some people have looked to see whether MR characteristics can be helpful at determining the grade of soft tissue sarcomas. And if you have peritumoral contrast enhancement, it can be helpful. Malignant characteristics in this particular study, when they looked at soft tissue masses, they actually found the size was not helpful. If you have fascial edema, skin thickening, contact with the skin, hemorrhage, inhomogeneous hemorrhage within it, necrosis, libulation, or peritumoral edema, those did correlate with malignant characteristics of the tumor. And then if we look at soft tissue sarcomas, when people looked at these, what were they? Well, about a quarter were really not classifiable by histologic criteria. About a quarter were leiomyosarcomas, dermatofibrosis, fibrosarcomas protuberans. We'll look at some of these, angiosarcomas, myxofibrosarcomas. Liposarcomas were about a third, MFH were about a quarter, and then leiomyosarcomas. And then found that MRI is actually quite good at predicting, at staging tumors when compared with surgical staging. What is important if the MRI, if the mass is around a major vessel, then if the contact exceeds more than 180 degrees around the vessel, then that really counts as encasement, which means that the tumor is not easily locally resected. You tend to have to do more of an amputation, because if it's a major artery, then you typically have to sacrifice the artery. So you really need to describe the contact of the mass with a major artery, and if it exceeds 180 degrees of contact, then that's a negative prognostic finding in this one paper. So we can look at some lesions that are kind of tumor-like, not really tumors. So why don't we start here, Shelley? What do you think of this mass?
Okay, so we have a young female with a tender dorsal mass on her wrist. So axial T1 and PD fat saturated images of the wrist and a sagittal T1. And so there's a hypointense T1 signal intensity but hyperintense PD signal lesion that's emanating along the dorsal aspect of the wrist, dorsal to the capitate, and going through the extensor compartment into the subcutaneous fat. I don't see any bone marrow signal alterations on this view. I don't think that it's coming, well, I don't see on any of the images any communication with any of the joints. So it looks like it's within the soft tissues of the dorsum of the wrist. Do you have any post-contrast images?
No.
No? So, okay.
So,
I mean...
So this is a dorsal ganglion.
Yeah, it's probably just a ganglion.
And they're extremely common in the wrist. And we typically don't give contrast for these, because this is a very characteristic location for a benign cyst. And this is one that classically the treatment was to slam a book on top of it. Not so much recommended in this day and age. These probably do originate from the wrist joints, and this is probably an basically extrusion of the capsule, and these are typically synovial lined, but not always. But these are kind of a classic ganglion cyst, and you just describe the location and the size, and these are. John, do you want to talk about the treatment of these?
Well, these are the most common. I'm sorry, was somebody talking?
Just you.
Okay. These are the most common areas for ganglion cysts, dorsum of the wrist. Why that is, I'm not exactly sure, but probably from pinching the capsule and the ligamentous structure of the wrist, because there's so much activity in that area in humans that there's always a degenerative change in folks as they get older. But it is extremely common. I can't tell you how many of these I injected with cortisone after aspirating the jelly that you find in these. The treatment, the best treatment there is, you just aspirate the jelly and then inject a synthetic steroid, like Aristospad is my favorite because that lasts the longest. That's the one that lasts for 3 weeks or so. And then usually they don't come back. And one of the secrets is you needle that area down to the joint, down to the bone, and you needle it 10 or 15 times, or whatever suits you. And then that produces scar formation and healing, and then the cyst doesn't come back. Now, if you do surgery on these when they recur, which it does happen if you don't do a very careful injection and aspiration and needling, and then you have to do a wide excision. The wrist becomes a little stiff after that, but usually if you do a wide excision and no new clefts form that produce another cyst adjacent to it, that usually is a cure. But I've cured so many with injections that surgical intervention is pretty rare. It was in my hands anyway, and I'm not a hand surgeon. It's not that big of an operation, but usually injection should help, and usually cures it.
Okay. Occasionally you can see these on the volar side, which I'll probably show some, but they're probably more common on the dorsal side because you have fewer structures to increase the pressure. On the volar side,
you're always extending your wrist when you grip things. You cannot grip things very well with the wrist flexed. So that's why Colles fractures are not very problematic in terms of function. They may look kind of ugly, but function-wise, they're great. But Smith's fractures with a volar angulation, they're bad news because you cannot grip with the wrist in flexion. Try it while you're sitting there and try to put some power in your grip. You'll notice that if the wrist is in flexion, you can't grip very much at all. Okay. Therefore, you become really quite disabled if you cannot do that, extend the wrist and grip.
Dr. Cruz, is microtrauma an etiology or repetitive stress to a particular tendon or a structure?
It's probably microtrauma / degenerative disease and repetitive motion of the wrist, which you probably get some irritation from just repetitive trauma, which develops an effusion, and then it just, with the increased pressure, it kind of decompresses, which is the weak point in the capsule.
There's some individuals that are just have a propensity for this. It's extremely common. I'm not sure I think I've seen probably as many women as men with the problem, but maybe women a little more. I just can't really say for sure. It's all from memory, but I've probably injected several hundred of these or more. It's a very, very common condition. The other parts of the hand and wrist are not that common, fortunately, because they're harder to treat.
All right, for next case, we have two axial images, T1 and T2. So probably between the fifth and the fourth digit along the volar aspect, I see a fluid collection which is kind of tracking down with a lot of soft tissue thickening around it. So another form of ganglion cyst maybe.
Okay. So this is, here is a
PD.
Actually, I think this is the first, second, third, and fourth. So this is the third and fourth.
Okay.
I agree with you. It looks like fourth and fifth just here. The little picky toes over there. Here's the axial images.
All right. So on axial images, it seems to be between the third and the fourth ray. So kind of see fluid collection like stretching out of between both of them. I don't see a well-defined collection as such. It's just fluid which is tracking along the digits.
So in a situation like this, you have to look to make sure there's no soft tissue in this.
Yeah.
And if it's just fluid, this is called intermetatarsal
bursitis. Okay.
What else? If there was a solid mass in this, what would you be thinking about?
Because I don't see any erosions as such. So I don't know what else to think of.
Okay, these are commonly associated with something that's a mass there.
Morton's neuroma?
Yeah. So the things to think about here when you see between the metatarsal heads, especially if it's the third and fourth and fifth, are Morton's neuromas. Now, Morton's neuromas are probably traumatic injuries to the interdigital nerve with scarring formation, but you often get bursitis next to it. In this particular case, this is just intermetatarsal bursitis. Probably trauma. Yes?
Morton's neuroma is a misnomer. It's really not a neuroma. it's a scarring of the nerve and pinching of the nerve, but it's not a neuroma.
Right. Yep. Okay.
But it's like Morton's salt. It's got a lot of publicity.
Right. Dan, what do you think of this case?
It looks like we got a 49-year-old female with hip pain. We got an axial, looks like maybe a coronal arthrogram of the T1 fat cell arthrogram of the hip, left hip. Where we see anterior to the labrum or acetabulum, there is this like low signal lesion, which maybe is like a cyst within the. I'm saying it's like a loose body within a paralabral cyst,
Okay.
or it's kind of deep to the vascular. It looks like a loose body.
Okay. So these are the vessels. What is this?
Vessel. Well, this is the labrum, and then this is the capsule, and this is like a contrast going from the joint outside. It looks like maybe it would be a labral tear.
Well, this is probably the labrum here. Do you know what this is?
So that would be just
Structure here.
the iliofemoral ligament capsule, or
Okay.
oh, I see. Let me see.
So what we're seeing then now, okay, so this is the hip joint, right?
Right.
So this is the femoral head. This is anterior. These are the femoral vessels, and now we've got fluid collection here. Adjacent to them, next to this is a tendon that's coming down.
Oh, this is the iliotibial. I'm sorry, like
right.
Not iliotibial.
So
iliopsoas, yeah, bursitis.
So this is the lliopsoas bursitis, and this is another very common location to see fluid collections. In this particular case, there was a loose body within it. I think it's probably the only time I've seen a loose body in the lliopsoas bursa. But this is another common location where you'll see bursal formation. So I just want to point this out. And this is the iliopsoas tendon coming down through here. Okay. Max?
Hello, everyone. So we got a sagittal T1 and PD fat sat sequences of the knee demonstrating a infra-patellar bursal fluid, large one, as well as a mild suprapatellar joint effusion.
So this is the infra-patellar bursa, and so I'm showing areas where you very commonly will see fluid collections, and this one in particular, it's amazing how frequently it's either not recognized or misinterpreted. These actually typically communicate with the joint space, and you can almost always see a little bit of fluid in this bursa if you look for it. So most of the time, our eye just ignores it because we know it's not important. This is a fairly large one in this particular case, which is this
patellar bursitis. Yeah.
If you look at the skin anterior to the patellar tendon, it looks like that area has been aggravated, probably in a chronic fashion, kneeling or whatever. But that doesn't look normal, does it, John?
I don't know what this image. It does look like there may be a little bit of edema. It is very common to get kind of chronic fibrosis in the subcutaneous tissues anterior to the patella and the patellar tendon. And as you say, it's probably because of chronic kneeling injury over the years. Yep. Okay. Jeff, what do you think of this case?
I have coronal T1 images through the posterior knee, actually in the also like a stir image also in that area, and we have a large septated lesion demonstrating hypointensity on the T1 images and hyperintense signal on the stir images. So we have sagittal T1 and then maybe T2 images in the same area, and this is a rounded lesion, again demonstrating T1 hypointensity and septations, T2 hyperintensity. It's along the posterior aspect of the medial femoral condyle in the area of the gastrocnemius tendon. So this this kind of complex cystic collection may represent a type of ganglion extending the area.
So this is another common area for a benign ganglion cyst. And notice that the margins are relatively sharply defined. We have no periostal reaction here. There are several other lesions which can occur in this particular location. The most common of which the most common thing here is just a benign ganglion cyst, probably because of an avulsion injury, chronic repetitive avulsion injury of the origin of the gastrocnemius tendon here, with then secondary ganglion cyst formation. In kids, we'll see you can get traction injuries in this location to the bone, which can be misinterpreted. And then occasionally you can have malignant lesions here, and we'll talk about those and how to differentiate those from the benign lesions when we get there.
John, do you think there is a connection between that cyst and the joint? I have a feeling that there is.
Yeah, I've always thought that there is. I think there probably is. Sometimes you can actually see fluid going up and kind of tracking into it, but not always. But I agree with you. I think it probably does communicate with the joint space.
Yeah, if you look at the knee joint, it's not exactly normal. No,
you've got grade 4 chondromalacia here. It's with remodeling in that lateral compartment. Okay, yeah.
Okay, so here we have some sonography of a 52-year-old male with the abrupt left hip contracture. I guess we're scanning the area of clinical interest, and we're seeing this kind of heterogeneous mixed echogenicity structure, some debris, and then we're scanning through again. Okay, now we're on to MR. Let's see. So these are axial images, and we see this sort of lobular intermediate hypointense structure with a slightly intermediate hyperintense rim. This was somewhat abrupt. It's sort of pushing on the lliopsoas kind of out like that. It doesn't look like it's invading the adjacent soft tissues or the bone, really. There's a little bit of hypointense signal of the adjacent bone, but I think it's okay.
The important thing here is you've got this hyperintense linear signal intensity and kind of amorphous signal within it. And that's what makes this different from most other lesions.
Sure. So that suggests sort of a proteinaceous type component, or perhaps blood. Okay.
Here are T2 weighted images, and you can see that now there's a lot of low signal intensity within it with a fluid level.
Okay. Well, I'd want to be sure that this isn't an abscess. It doesn't show any like adjacent issues or anything like that. Another possibility would be just muscle injury and hematoma. Okay, I'll take it.
So this is very characteristic appearance of hematoma.
So axial and sagittal MR images of the knee, the axial images of PD fat saturated sequence, and there's hyperintense lesion along the within the subcutaneous soft tissues, and it kind of drapes over the patella. Then the sagittal T2 image, there's a fluid level within it with dense material layering dependently. So this could be, if in the setting of trauma, it could have been maybe like a Morel-Lavallee type lesion or a hematoma. Oh, you can see it better on your computer screen. Yeah. I can't see it all on ours.
So they're fluid levels, and this is a Morel-Lavallee lesion. And then these are typically glancing blows to the skin, where you get compression and then this lateral displacement of the skin, so that you basically get tearing along the deep fascia of the skin. You then get hemorrhage, and then you get this pocket, and it has difficulty to heal because the hemorrhage keeps the tissues apart so that they can't heal again. So these have to be basically aspirated and get compression bandaged, and it can be a problem getting these to heal, and they can become very chronic lesions.
Yeah, it's compression and friction
Yeah.
And so what you have to do with these is, I think I mentioned this before, is you use a brush that you clean bottles with, a bottle brush, but I'm sure it's more fancy in orthopedics, and probably costs 50 times more. But that's what you use to roughen up the surface, and then compress it and put in drains, and that usually does the trick. You can't cut. You cannot cut corners with this, otherwise they'll come back and you get infection, and that's a miserable situation. Most of these lesions are actually up on anterior thigh and above. This is usually, I suppose, around the knee is not that uncommon, but I've never seen one around the knee. But it's usually up in the thigh.
Right.
Anteriorly. It's not a condition that you just forget about. You treat it and vigorously.
All right, we have a couple of corneal images. I think the first is a PD. Yeah. So all along the joint space, I see a lot of heterogeneous rim enhancing. I know we don't have a pre-image, but there's a lot of heterogeneous fluid collections all along the posterior. Yeah. So it's just PD and PD fat set. All right. So I see a lot of heterogeneous tissue along the shoulder joint, mostly posteriorly, anteriorly, a lot of synovial thickening. The glenohumeral joint space is kind of increased with, okay, and it seems to be just synovial thickening. I don't know whether this collection or, so okay, we have like corneal images where we see that the supraspinatus muscle is almost, I don't see supraspinatus muscle tissue as well, neither the tendon. It's all replaced by irregular scar tissue or.
I don't see much of a tendon.
Yeah. So. Yeah. So on the sagittal images again, I cannot see the supraspinatus or the subscap or any of the rotator cuff muscles, and the acromioclavicular joint, although partially imaged, it also appears kind of
what do you
weird.
think this is? This is a huge surrounding low signal intensity soft tissue mass with not a lot of involvement of the bones.
Is it like PVNS or Milwaukee shoulder, perhaps?
This turned out to be amyloidosis.
Okay.
And this here. So this patient has. So when you see low signal intensity masses like this around the joint space, the two things to mainly think about are PVNS and amyloidosis. And in this particular case, this patient had. You can always check to see whether they're calcified, though. I don't think I've ever seen a calcified mass that's this diffuse around a joint. So you typically have either ultrasound or plain films to correlate it with, and if there's no calcification there, then really amyloid and PVNS are the things to think about. And then you check to see whether it's bilateral. PVNS is typically only one joint, so if you're dealing with something that's bilateral and involving multiple joints, then you're really thinking about amyloidosis.
If it was calcified, what were you thinking of?
Or if it was calcified, then you can sometimes get large calcified masses after trauma. You can look at hyperparathyroidism and multiple brown tumors, but you can have brown tumors also that aren't calcified.
And this would technically be a brown tumor in the synovial in the joint space?
If it were hyperparathyroidism,
okay.
Which it's not. And okay, Dan.
Yeah. So we got two sagittal and two sagittal and axial images of the digit. Looks like we got Sagittal images, these are T1, I believe.
T1 and T2.
T1.
T1 and T2.
Okay. So it looks like it shows maybe better on the axial. At the very tip of the digit, there's just like a subcutaneous mass. Where on the axial image, it looks like it's dark on that PD fat SAT image, I believe. There. So it looks like a, okay, yeah. So it looks like we got this fourth digit globular mass adjacent to the bone, but there's no obvious cortical destruction from that axial image that we had previously. So giant cell tumor of the tendon sheet would be high on the differential given location dermatomyositis.
Oh, that's the other thing I think about. Often with dermatomyositis, it's typically more in the skin, but you can get large calcified lesions, but it's primarily involving the skin.
So this one you would include brown tumor as well?
I've never really seen a brown tumor in the distal phalanx like this. I think more PVNS or giant cell tumor or dermatomyositis.
This is diffuse. It's involving both digits?
No, I think it's
all
only,
of here and here?
No.
Like with this?
No, I think it's only involving this one digit. Okay. But it certainly could be involving multiple digits with dermatomyositis.
Yeah, I think it's more systemic than one digit.
Yeah.
Usually, so that this is probably a bit of an unusual.
Yeah. And okay.
Those header, there are some also hypointense areas more proximally. Looks like as well. Are those also more lesions in that?
Where?
Overlying like the proximal phalanx.
You need more cuts.
You're talking about these things here? I think these are just the muscles. The way the image is, it's a very kind of contrasty image here. I think the only lesions that we see in this particular case are the ones here in the distal part of the finger. Okay, Max?
Yes. So we have two chrono series of the wrist. There is a T1 on the left and stir on the right. There is a large low signal intensity on T1 weighted sequence mass occupying the ulnar aspect of the wrist and possibly maybe even arising from the ulnar head, ulnar stylet, because I can't see the ulnar itself. And it extends into the region of the carpal bones, and it's a heterogeneous signal on T2 weighted sequence. Yeah. So
wherever you have these lesions, you're also getting bony erosive changes.
Right, there are multiple additions. So this is.
How would you go about dictating a report on a case like this?
Well, I mean, you discussed. I mean, this looks like a long-standing process because I mean, you get these bony erosions and remodeling of the bones, and.
Well, that's not what you put in a report, I don't think. But where do you start? Well,
I first talk about the signal of the mass, the size of the mass, where it's located, if it's involving any other structures, if it's causing erosion.
One mass. There's not only one mass. Right. I'm not being silly about asking that question, but to dictate a report on this is kind of a difficult thing to do, I would think.
Well, not really, because I mean, first of all, we don't see just one slice. We see the whole study, and then it's easier. Like right now, I didn't know if it was cutting wrong.
The way I would start dictating is multiple joint involvement with erosive changes, and then tumorosities here and there and everywhere. And that's how I would proceed probably. And only a few joints are almost normal, not quite.
Yeah, but what we're looking at here is a series of masses that are low in signal intensity. So that's the differential that we're looking at right now.
Okay, so these must be calcified masses within the joint spaces predominantly. And then they're better seen on the axial follow-up series you were showing. Yeah, you can see those little rice bodies, almost looks like a rice body. So
this is a T1 and this is a T2. And what we see
is
large, bulky masses that are eroding bone that are low in signal intensity in both sequences.
So
what does that lead to?
Pigmented venonodular synovitis or synovial chondromatosis. Those were the two things I would have think about.
Why synovial chondromatosis? You think these are all calcified?
That's I've never seen a case of that in so many joints.
I mean, the other thing is some form of systemic disease. I mean, we talked about amyloid earlier. Amyloid could be low signal on both.
Of course, I think that this is systemic.
That's a scleroderma.
So this is scleroderma. So diagnoses, and these are in the extremities like this. So there are a number of pathologic entities that involve the soft tissues that can involve the whole body. In this particular case, we just saw one dermatomyositis before. This is scleroderma in this particular case. So there are a number of disease processes which primarily are fibrous tissue, which are low in signal. So I'm just showing a bunch of them right now so that you can kind of associate these diagnoses with low signal intensity masses. If you go back to that flow sheet that we had before concerning, first you look at the T1 weighted image and see if it's low on T1 weighted images. Then you're thinking about fibrous tissue. You're thinking about calcified tissue, or you're thinking about blood products. If you go then to the T2, and if it's low in signal intensity, you're really kind of thinking about that same group. So seeing that this is very low in signal intensity, then we're really looking at one of those lesions. It's either going to be fibrous, it's going to be calcified, it's going to be amyloidosis, or it's going to be hemosiderin deposition, which is going to be in PVNS. So those are the kind of things we're thinking about. So here's just kind of a list then to go over. If you see low signal intensity masses in the periphery, think of hematoma, PVNS, fibromas, sclerosing perineuroma, scleroderma, and dermatomyositis, because that's kind of the list of things to look at in that category. These are all the non-calcified, low signal intensity masses. Okay.
Dr. Kus, can gout be multifocal like this?
Gout can look just about anything. About like anything. So if they're calcified, then you can put gout in that category. These are the non-calcified ones.
Okay. So those can involve the joint spaces or the soft tissues.
Gout can.
No, of this list, because you showed examples. Okay.
Yeah, these are primarily soft tissue lesions. They can involve the soft tissues around the joint, but they're soft tissue lesions.
Okay, because I guess the last case was a little confusing because it was involving and eroding portions of the wrist. So
that's right.
Was it coming from the soft tissues and going basically?
Yes, it's a soft tissue lesion that's externally eroding the bone.
Okay.
Yeah. If you've seen people with long-standing scleroderma, they get marked deformities.
Yeah.
And it's due to the bone destruction that they have in remodeling.
So just an outside.
You lose circulation. That's one of the biggest problems with scleroderma. It's loss of vascularity.
Yep. Okay. See Jeff.
So we have an 81-year-old female with a right posterior thigh mass and rule out a neurogenic tumor, and we have four sonogram images demonstrating an echogenic lesion. Looks like it's subcutaneous and superficial to the muscles, and there is vascularity associated with it.
And a lot of through transmission too.
And through transmission.
Okay, and this was a nodular hydranoma case. So benign hydranomas They're rare benign skin lesions. They're solid lesions, but they tend to have through transmission, like you might expect of something that's more like a cyst. And they're usually solitary, slowly growing. Okay.
Okay, so here we have an ultrasound and some MR images. The ultrasound demonstrates this mostly hypoechoic with structure with some debris and through transmission. Looks like they did Doppler, and there is some flow within it. Then moving to the MR. So I guess we've got, I'm not entirely sure where. Well, anyway, at any rate, there's this lesion within the subcutaneous soft tissues that's kind of protruding above the skin. Looks like we're, yeah, post-contrast there, kind of peripheral and central enhancement with, oh.
I think this is another
Oh, okay.
Interesting. Tumors that have fat within them. Okay. And then we kind of already talked about this, but there are a bunch of lesions that that can present with fat, both benign and malignant. The sarcomas, you tend to have more inhomogeneous signal intensity. When it's the medium to high grade malignant tumors, they tend not to have MR detectable fat within them. The fat is microscopic in those. You see it under the microscope. So, and then, so let's look at a few of these. Why don't you take this one?
Okay. This is a little more like it. So we've got an axial view of the patient's thighs, and over on the right thigh, we're seeing this large mass of fat signal. I'm not seeing any septations or nodularity. Okay, here's T1, T2, and stir. So on stir, it completely drops out. This looks like a pretty good lipoma, although it is a little bit on the large size. That's the one.
Yeah, the lipomas can become very large and benign, and there are rare cases that I've seen and that have been described in the literature where you can have complete uniform high signal intensity with sharp margins on the T1 weighted images, and histologically they find sarcomatous elements within them. These are extremely common. I know I've seen patients that have had 30 or 40 of these in their body. And overall, I think 99% of the time, if you see a lesion that's completely uniform T1 weighted image, bright on T1 weighted image with smooth margins like this, you can reliably, comfortably call it a benign lipoma. And I have done that for many years now, and I've not had one that turned out to be malignant, but they have been described. But I think that MR is by far the best way to evaluate these. It's better than biopsy. The problem with biopsy is sample error. If these kind of lesions may have those sarcomas in them, they're typically not the whole lesion, and you can miss them by biopsying. So if you do surgery, and they have to remove the whole thing. But
yeah, you don't biopsy lipomas. You just excise them. Yeah. The main thing is you excise the feeder, blood vessels, and there might be some small nerves going with the bleeders, with the feeders. Feeders being artery and vein, and that's the area where you really want to get to. Otherwise, they will recur, and you must not cut corners. You have to take out the whole thing, otherwise they'll be back. I've frankly never seen a malignant lipoma, but I've seen them on slides. And I think you probably described these, John,
yeah.
With large septi, et cetera, et cetera.
Yeah, well, I'll show some more malignant ones in a minute. Okay, let's see. You did last one?
So 36-year-old male.
One thing I'll add to that, these are really fun to remove. all you do is stick your finger around that capsule and it just comes right out. But then you have to search for the bleeder site, and that's the area that you have to be very careful with.
Sounds like a true surgeon.
Oh, it's fun. These are fun to do because the results are so nice.
And do you remove a margin around that lesion then?
No, you do not. You just shell it out. The only place where you go deeper is where the feeder vessels are. I've never had a recurrence. I've probably done 1,000 of them.
Okay, so 36-year-old male with a palpable mass lesion at the left thigh for a year and pain for 2 months. So T2 and T1 weighted images in the coronal and sagittal plane. There's, on the T1 weighted images, hyperintense lesion with areas of internal septations. Most of them are thin, but along the inferior aspect of the lesion, just medial to the hamstring musculature, or maybe that's the adductor musculature. It does have some areas of thick septation, and on the T2 weighted image, there's, again, some hyperintense area inferiorly corresponding to those thickened areas of septation. Yeah, so the entirety of the lesion doesn't suppress out. So this could be, so the fatty lesion, I wouldn't really just say that this is a benign lipoma. Just the septation inferiorly is a little suspicious. So they're turning benign.
They were concerned about this also. They excised it, and it was completely benign even down there inferiorly. So, you know, the literature isn't entirely clear, but what it says, if you have septa that are thicker than 2 millimeters, or if you have a nodular type septal thickening, then you have to be concerned about the increased risk for malignancy within the lesion.
Yeah.
So this would be one that would be considered suspicious. Now, what to do about these? You can follow these closely. The vast majority that look like this are going to be benign. So it's not unreasonable to follow these, though a lot of these individuals want these out because they don't like the deformity that they produce, especially when they're large like this.
So will you dictate surgical consultation?
No. Well, no. On a situation like this, what I do is I dictate this and say that the inferior aspect is not clearly benign, and then you talk to the doctor on the phone. But I do not describe this as a benign lipoma. I then describe it as a primarily lipid-containing mass. Within the inferior aspect has septal thickening, septal and nodular thickening, which is not clearly benign. And then you need to talk to
that's the feeder site, and you can always say suspicious, or whatever.
Right.
So even in this lesion, you would not take out a margin?
Well, you cannot say that it's clearly benign. You don't want to stick your neck out. What you want to do is cannot rule out malignant change or whatever.
Yeah, I think that's any wording along that line. And I talked to the physician, and they may have their own suspicions and would like a certain kind of wording. But this is I'm blocking on the word I like to use. You can't. This certainly is not a clearly benign lesion, though more than 90% of lesions that look like this will be benign, but not 100%. It's a suspicious lesion.
DYA.
Okay.
Is morphology the only criteria? Size is not a criteria to determine whether a lipoma is typical or atypical?
Size is not a good criteria because benign lipomas can get very large. And And a lot of the sarcomas I've picked up have been smaller, actually, and that's because I think sarcomas tend to be symptomatic earlier on, whereas lipomas sit there for years and years without any symptoms and can just grow very slowly, whereas sarcomas tend to produce other symptoms when they're smaller.
Is there enhancement criteria at all?
Yeah, if you have nodular enhancement or if you enhancing septa greater than 2 millimeters in thickness, then that's got to be considered suspicious.
Okay, so for next case, I have chronic wrist pain and swelling. So I think I have two axial images, one with T1 weighting and one with kind of PDF fat saturated images. So just along the volar aspect of the ulna, I see a lot of nodular synovial thickening.
We see this mass.
Yeah, and along where the soft tissue marker is, just along the volar aspect of the flexor tendons, again there is like a large soft tissue mass, which kind of appears really bright on the PD sequences. So, and slightly distal axial image. Again, I'm concerned for the area which is like lateral to the where flexor tendons are.
So this is the lesion, and this is proximal to the carpal tunnel. If you go to the carpal tunnel, it goes down into this lesion.
Ah, okay.
And this is the hand.
All right, so I see that lesion extending really distally to involve even the hand. I don't remember the name of this disease. Is it some fat-containing lesion of the nerve?
Yeah. This was a fibromyalgia.
Yeah.
In this particular case, which we can see here, we can see that it's really kind of an infiltrating but a benign lipid-containing. It has both lipid and muscle cells within it in this particular case.
In one of the previous lectures, I think we did one of the fatty transformation of median nerve. I don't remember what that was called. Hematoma or
that's a hematoma. Why am I blanking on the name? Which isn't that rare. You'll see a couple of them every year.
Some kind of hematoma. I don't remember the name.
I'll think of it in a minute.
Yeah, sure.
That's crazy. Yeah, but this was a fibromyalgia. Okay, Dan.
So it looks like you got a 40-year-old female with a mass on the right inguinal area. We got a frontal radiograph of the right hip, which the bone actually looks normal. I don't see any soft tissue mass on this X-ray.
There could be something in
I mean, I guess to hallucinate there is something there. We got axial and coronal images of the thigh, where it just shows this kind of like a fat-containing mass with some internal subtations, but which actually drops out on the fat side images without significant enhancement. So lipoma within the musculature, probably like the adductus magnus.
Okay. Well, where do you think there's the enhancement?
I see some vascular going through it, and but I don't think it enhances much. It's just maybe like a little bit peripheral, but no nodular or central enhancement.
I thought you said it did enhance a lot. Okay.
It did not. I said.
Okay, fine. Okay.
Yeah. And on this image, which is lower, we see some central
fat set.
Right. So I wish we had like a kind of like a fat set image to show that that enhancement or increased signal is actually increased from the pre.
Right. I agree with you.
If that's the case, that would be just like mild enhancement of the central fibers. I guess liposarcoma could not be entirely excluded given the size and some maybe internal.
Okay, so this is what it looked like when they removed it. They removed it because it had a lot of elements in it that weren't just lipid, and so they were concerned about this being a liposarcoma. And this is what it looked like histologically. You can see all the fat cells in it and the stromal cells. And this was a hybridoma. So this is a lipoma, but of brown fat. And they characteristically have these internal structure in them that look a lot like what was seen a little bit. Could be a liposarcomatous elements within it. But this is, these are benign as well. But this was removed in total. And actually, I think we're kind of at the end. Why don't we, I think this is a good place to stop. And we'll pick up here next week.
Sounds good. You guys have a nice weekend.
Any questions? Okay. Thank you.
John, I will not